Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
As much as we've learned about ocular surface disease, there is still so much yet to be discovered. The good news is, this creates a world of opportunity for eye care providers.
The goal of this podcast is to better understand this chronic and complex condition and keep you up to date on the advances being made in its diagnosis and treatment. So let's get to the point. Welcome to another episode of the To The Point podcast. My name is Jackie Garlich, and I'm joined by my co-host, Jessilin Quint. Hi, Jessilin. How are you?
Hello. Hello to all of our listeners. Jackie, congrats on hitting 1 year of your EHR. I saw that on Instagram. That's like such a milestone, right? Because then you don't have to enter in new data. So major props. It's a good feeling.
Thank you so much. We're almost to a year, but it was today that I realized I had another comp patient come back, and I was like, they're already in my system. I don't have to transfer it from another system. How incredible it is. So thank you so much. I'm glad only, healthcare workers, I feel like, understand the pain of switching EHRs.
So true. And our next guest, I'm sure, because he is an amazing eye care provider. He's probably been through his number of EHR shifts throughout his lifetime. But this guy is just, he wears so many different hats and somehow still finds the time to still continue to teach all of us. Dr. Damon Dierker, he's the director of the Optometric Services for Eye Surgeons of Indiana. He's the founder of Dry Eye Boot Camp, co-founder of Eyes on Dry Eye. He has been the former president of the Indiana Optometric Association. And I would say he's one of the most sought-after educators in our profession. I feel like when you're around him, he's like maybe a little quiet, but boy, when he talks, you better listen because he is going to drop like this knowledge bomb on you, and you better have your pen and paper ready to take notes. So, Damon, thank you so much for being here. Welcome to our wonderful podcast. We're excited to have you.
That is quite the intro. I appreciate it. I do have an updated title change. I am now Director of Clinical Strategy and Optometric Services at Eye Surgeons of Indiana, which better encompasses kind of what I do on a day-to-day, week-to-week basis. So I've been in that role for some time, but there was an official shift here in the last couple of weeks.
That's awesome. I feel like you're perfect for that role. And Damon, I don't know, you probably know because I've talked to you about this, but so the listeners know you have been very instrumental in my dry eye career progressing. I mean, I talked to you from the very early days before I bought anything into my office. And I feel like you provided, and still do, I still will call you about things like great advice, and it makes sense that you are now have a strategy role in what you're doing day to day because you're very good at that. So I'm happy to have you here and pick your brain on a few topics tonight. But so thank you for guiding me as you always do. You're a great friend.
And congratulations again on 1 year at EHR. That is an important milestone. But I've been through that a couple times, and sometimes it feels like it's about 5 years before you get to year one. So
I know.
well done.
Yeah, great. I love it. Well, I we want to pick your brain, Damon, on loose conj, right? Conjunctivochalasis, chalasis, depending on what part of the country you're on, how we pronounce it. But it definitely plays a big role in ocular surface disease. So from your experience, how do you just approach that, navigate that? How do you kind of chase that versus putting out other fires? What is your strategy?
So my strategy for anybody that comes in with ocular surface disease is I try to figure out what symptoms they're having, try to understand their history, and then through history, exam, point of care diagnostics, I identify etiologic drivers. And a lot of the times it's MGD, blepharitis, inflammation, systemic disease, but sometimes it's mechanical, and sometimes it's a combination of these things. So when I tackle it's pretty rare that I would go after conjunctivochalasis as the first thing I try to treat for somebody, because I think there's other things that are maybe easier to treat and more common. Not that it's uncommon, it's probably underdiagnosed and undertreated, certainly. But I think things like inflammation, MGD, tear insufficiency are much more common and much easier for us to manage as optometrists. So in most of the cases that I see, patients that have conjunctivochalasis that I'm actually addressing, it's because I've done other things to treat their other drivers, and they're still symptomatic.
Mhm. I was just gonna say that, I have the same philosophy. I never go right to that just because, as I tell patients, there's never just one thing that's creating their problem. And so, there's a lot of things. And so I think hitting the most obvious or the things that seem the most offensive makes sense. Are there certain symptoms or staining patterns, signs that you see that make you think, oh, this conchalasis is more of an issue, and, it's really that tear film distribution that's impacting this patient's comfort? Are there specific signs or symptoms you're looking for?
I mean, I certainly think that you will see a tear meniscus that is disrupted in some way. And the best way to do that is put some fluorescein in the eye with a strip, and you'll see conjunctival folds. You'll see a tear meniscus that's very irregular. But as far as your question, it would be somebody that probably the top two, I would say, are persistent epiphyseal tearing and then foreign body sensation that they can localize. It's like this eye is always right here. And then sometimes you can literally manipulate the eyelid and relieve the discomfort and say, okay, well, clearly that's it. So I think those are the two biggest ones. But certainly you can have other classic dry eye symptoms, irritation, fatigue, vision worsening later in the day. But top two probably are tearing and foreign body sensation.
Whenever a patient has those symptoms and you really have kind of honed in that is likely the cause, at what point do you actually then kind of start to do treatment? Is it like a certain speed score? Is it just kind of up to the patient of like how tolerable is it? Is there like a certain amount that you're kind of looking for? Hey, how do you gauge that like tipping point to where we're like, all right, maybe we do need to kind of look at different treatment options?
So when you start looking, I would say a significant minority of our OSD patients have some amount of conjunctivochalasis, more than trace, right? So then you look and say, how much is this actually impacting the symptoms that they're describing? And then are there other things that are going along with that that are maybe causing their symptoms that I can't address? So what I want to identify is if I'm going to treat somebody myself, it's probably moderate conjunctivochalasis and not severe, right? I'm probably not treating mild. I'm probably treating moderate. Severe probably needs a surgical excision and amniotic membrane. Or some of these patients, they have tearing. They're older. They have really lax lids. They have ectropion. They have conjunctivochalasis that's hanging over their puncta. I mean, those are patients that are best managed in the hands of the oculoplastic surgeon. The ones that I think are most straightforward for us to manage are going to be ones where it's more focal or more in the moderate severity. 2+ conjunctivochalasis. Clearly, you can see it, but it's not 4+. It's not trace. So those are patients that we certainly want to treat any inflammation that we can first. And if someone is not responding to anti-inflammatory therapy, that's going to be one of the signs that tells me I'm probably going to have to treat their mechanical dry eye.
So speaking of treatment, how do you treat this? Certainly I've referred patients to ophthalmology for these treatments, but how do you handle that? How do you treat that?
So I think there's pretty good evidence that we have both clinical experience and some papers that have been presented that using brimonidine, over-the-counter Lumify can help patients with mild to moderate conjunctivochalasis. But then if we get to patients where clearly they have something that I think I need to be doing some sort of more significant intervention, it would be doing a plasma pen conjunctivoplasty in the office. And in Indiana, that would be considered part of our scope of practice. And that's something that I've done a handful of. I think that that will probably continue to accelerate a bit. Both myself and one of our cornea specialists in the practice are doing that now. And then we kind of decide, in most cases, we try to see if we can help the patient in office. If we can't and it's more substantial, then it's either the cornea specialist going in and doing a more significant conjunctivoplasty in the OR, or referral to oculoplastics if there's other lid issues in addition to the loose redundant conj.
Walk us through what a plasma pin is. If somebody's been in the aesthetic space, you've seen plasma pin used by estheticians to like make skin kind of get rid of wrinkles, make skin tighter. But is it a different pin? What does it look like? Maybe if somebody's like, what is plasma? Give us the lowdown.
So it's a handheld tool that converts electrical energy into a plasma stream, and that is going to cause a thermal injury to the conjunctiva and kind of cause contraction and tissue remodeling. So it's a it used to be that prior to plasma pen, if people were doing this in the office, they would use a cautery. And that's, very aggressive. There's more collateral damage. It's more uncomfortable for a patient, but it's the same sort of concept. So if you can think about if you were using a cautery pen, a plasma pen is just a more elegant way to do that, where we're trying to do the same sort of thing as transfer energy to cause some contraction of the tissue so that we have better tear clearance, we have less redundant bunched up conjunctiva, better tear reservoir. All of those things can be accomplished by thermal energy, which shrinks the conjunctiva and gives it a more normal anatomic appearance in relation to the eyelid and to the scleral wall.
What does that procedure look like for the patient? What is their, anything pre-op? What happened? How long is the procedure? And what is like post-op care like?
So the procedure when I've done these, I found the easiest thing to do is to do this not behind the slit lamp, but with loops on. So I'm in free space. The patient's in an exam chair. I can do this in an exam lane or I have a treatment room. It doesn't really matter. I just want to make sure that I'm comfortable position wise and the patient's comfortable. They're leaning back a little bit. I give them proparacaine and or tetracaine drops. I do have a tetracaine gel that is helpful as well, and just try to get them to a point where if I'm touching them with a surgical spear or something like that, they don't really feel a whole lot. Another thing that's really helpful that I regret the one time I forgot to do it is you do wanna put some Lumify in the eye because what that does is it kinda shrinks the vessels a bit because you don't wanna necessarily create a thermal injury to a blood vessel because you can get a significant subconjunctival hemorrhage and your procedure just ended prematurely. So then what I do is I look at the patient in the slit lamp, they're numbed up, and I kinda have a game plan for what I'm gonna do to try to contract the tissue where I believe that their problem is coming from. And that is going to be avoiding the limbus by a couple of millimeters. We want to avoid that area. And then I'm creating 2 or 3 rows, typically spaced out by a millimeter or two. So for a lot of patients, it's maybe 20 or 30 spots that I'm using with the plasma pen to cause focal contraction of their conjunctiva to normalize that tissue. And it's actually a pretty fun procedure to do. The patient has minimal sensation when you're doing that. You can see an instant improvement in the tissue, and your endpoint is, you're not trying to get a full burn, you're just trying to see that contract. So it's literally half a second maybe that you're doing, point by point, and maybe the procedure in most cases takes 30 to 60 seconds for the patients that I'm treating. I'll treat one eye at a time. I'll do a couple spots and make sure that the patient's comfortable. And I found that it's a pretty easy thing to do. And what's really interesting is within a few days, the patients feel better. If that's their problem, they feel better. I do put them on a combination antibiotic steroid drop for a week after. Can have a little bit of transient discomfort for a couple days. I've not had anybody that's had more than mild discomfort. And I would say that I'm probably shooting about 80 to 90% of patients having significant symptomatic improvement when I'm treating them with a plasma pen conjunctivoplasty.
That's awesome. And to be able to have an option that's a little bit less invasive, right? Probably maybe a little less downtime than just a cautery or sometimes even different types of radio frequency. I think that's a great option for patients. Is there any patient that this would be like contraindicated in that they just like, it would be a, do not go past go?
If you have a patient that you try to do anything to them at the slit lamp in the least and they're jumping out of their chair, I probably wouldn't do that. So I think just common sense is is this patient gonna be agreeable to this or not? And you can pretty much tell in a comprehensive ocular surface disease exam if they're gonna be like that when you're touching their eyelid and looking at various things. I can tell who I probably is not gonna be in my first 20 patients I'm gonna treat.
Is this something that's covered by insurance?
This is covered by insurance, although the code is not straightforward. I think that it is reasonable since the codes that we have don't exactly describe what we're doing. It would be reasonable to do this as a self pay or cash pay procedure. And certainly there are doctors that do that. There are some destruction of tissue codes that can be used for the conjunctiva that would be acceptable as well. So that's what I'm currently doing. I think that as I continue to do more and it fits into some of the other things that I'm doing that are self pay for ocular surface disease, I may transition this more towards the self pay procedure to better describe exactly what I'm providing for the patient.
Like it. I mean, just a knowledge bomb, right? But don't go anywhere, guys. We're going to take a quick little break. We're going to hear from one of our sponsors, and we're going to come back and we're going to pick Damon's brain on a different procedure that maybe also involves loops. So stay tuned.
Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
All right, we're back from the break. Let's talk a little bit more about ocular surface disease and specifically the use of Lacrophil. And so I'd like to hear from you, Damon, on how you're implementing Lacrophil in your practice. And have you switched over all of your silicone and collagen, plug patients into Lacrophil, or how are you handling that? And who's a good candidate for that?
Yeah, great question. So I was not much of a plugger. I don't know that I've done a silicone plug in 20 years, probably. I've actually done punctal cautery more recently than silicone plugs. Slowly absorbable collagen plugs I did infrequently, but Lacrophil or hyaluronic acid gel is canalicular occlusion, so it's not a plug. We're doing a more complete occlusion, customizable occlusion of the nasal lacrimal outflow system with the gel that's 98% water that's your body slowly breaks down and kind of leaches out, and it's a very comfortable procedure. So for the same sort of patients that would be candidates for a plug are a candidate for canalicular, obstruction or a canalicular procedure like Lacrophil to basically block that outflow. So aqueous deficient dry eye, Sjogren's, neurotrophic SPK, post-surgical dry eye, pre-surgical dry eye, trying to be proactive there. A lot of different reasons to do that. And I think what's been really cool about it, I mean, the things that we don't like about plugs, reason I don't do silicone, I don't want to carry this huge inventory of plugs and I'm not really trying to say which plug am I trying to fit for this patient is that no, which patient is going to benefit from tear retention. So that's my algorithm. Who's going to benefit from tear retention? That's a symptomatic patient that has a low tear meniscus for the most part is going to be your low hanging fruit. So for me, I'm definitely doing a lot more of these than I would have plugs. I would say that I do it on a daily basis. I wouldn't say it's my go-to for everything, but I'm accelerating my use of it because I have patients that just come back and say I want that because it lasts for about 6 months. And I have patients, I literally had two of them today that came back. They said, "Yeah, it was good for 4 or 5 months. Now I can tell I need to use my teardrops again. I'm ready for Lacrophil." So there's not a whole lot of procedures that we have like that. I do have patients come back in for IPL or thermal procedures that say, "Hey, it's time," but it is not unusual for a Lacrophil patient to request another treatment.
So walk us through when you're doing that treatment. Do you use loops? Do you not use loops? Different schools of thought there. What does that look like? Do you numb the patient? Do you do all four punctum?
Yes, and yes, yes. So I do all those things. I would say that what's actually been fastest now for me is I used to do them all with loops because I'm so used to doing probe and irrigation and things out the slit lamp that is just faster for me. Now I found because I'm right-handed, I'm always, feeling like the slit lamp light source is in the way. For me, I do the patient's left side with my right hand, and it takes me about 30 seconds. I step outside of the slit lamp, I put on loops, I do the right side, and it takes me about 20 seconds. So that's my process there. And it has to do a little bit with just kind of how the chairs are in our lanes too. It's easier for me to be on the patient's right side in most of our lanes. And it's easier for me to work with my right hand when I can. So that's how I do it is I can do it at the slit lamp. I can do it in free space. Now I've kind of got a hybrid. I don't know how many people are doing that, but it's fast and the patients don't really feel much of anything and it works great.
I'm just gonna tell everyone you're ambidextrous. I just feel like in every scenario, Damon can do it all.
That is the first I've heard of the hybrid model, but now it kind of makes me wanna try that. I do it in the slit lamp, and then I have to move my illumination arm over because it's the same thing. For their right eye, I'm using my right hand and angling it's like it's a little bit awkward to do it, so I should
And you've
maybe
got little girl hands. I've got big guy hands, right? I mean, imagine it's like I run outer space there. So that's where, and then, I've done things like Dextenza before, if we were in studies for Dextenza, and I'm just so used to doing outside the slit lab, it's actually the easiest. So sometimes it's just where the chair's at, how the patient is. And I just want to make sure I do it as efficiently as possible. It's actually, once you do a couple, it's faster than putting in a plug for sure.
Yeah, the left eye is super fast. When you as you're saying this, I'm like, "Yes, yes, left eye's really good, right eye takes just a little bit longer." What are you hearing from patients? So patients are liking it, but on their initial, like, day or 2 out from Lacrophil, are they if you're occluding all 4, like, the entire system, you would expect that the patient would have a lot of epiphora, and that really isn't what we're seeing. I mean, that for or in my experience, that's not what I'm seeing. I don't know what if your patients are noticing that, but is there what are they like the first day or 2? Do they talk about epiphora or
So I think that I have maybe 4 or 5 patients out of several hundred that had some epiphora for the first few days. With this, you can flush it out if you needed to or wanted to. I've never had to do that. So I think that in my experience, if you're choosing the right candidates, if they do have epiphora, it's short lived. In the clinical trial, comparing this to a plug, it was much less than 10% that had epiphora. In clinical practice, I think it's probably even less than that. So the patients, you're getting some of this hyaluronic acid gel, it's similar to a dermatologic filler. It feels good when it's on the eye, so that patients feel some of that immediately when they come out of the procedure. So they have something that even the first couple of days say, "Oh, wow, it really feels good." And then you have this complete occlusion that's keeping the tears on the surface of the eye longer. And people really like how that feels. And it's even people that have had plugs. And then we either the plugs dissolve or we take the plugs out and do this. They strongly prefer Lacrophil, in my experience, to a plug.
I would agree. So many different uses for it, and I was kinda like you until we had this, I just didn't really ever do a plug, right? Right, pulling out, it would go flying across the room, it was a whole ordeal, but I love so many different facets, and so I approach it differently. Another great use that I found is, like, contact lens discomfort. Of course, there might be other things going on, but, that's sometimes a big one, and sometimes for patients that wear contacts, it's not as always feasible to take the contact out to do a certain drop, and so in addition to surgical patients or just adjunct therapy to other dry eye treatments, it's been a real game changer.
And it's a covered procedure. So there's a lot of patients that have challenges with prescription medication or putting drops in. Contact lenses, I agree, perioperative is a big one too. So I think there's probably a lot of uses, and I would say I probably still underuse it in terms of how I could improve patients with this procedure.
Yeah, it's a good point. A lot of the things that, all of us offer are there could be really great therapies, but are out of pocket for the patient, and so having something that is covered by insurance can be, that you can offer that is new and does, move the needle with patients can be very beneficial for sure. Okay, we've covered a lot. We did conjunctivochalasis, we've done Lacrophil. Jesselyn, any final thoughts here? Or anything else you wanna ask Damon before we let him go?
Man, this is like the world is our oyster. Uh, David, any clinical pearls, right? Like, if you had to just say, like, any for the listeners, right? Just, like, one other clinical pearl for either of these procedures, anything that you just wanna make sure you drive home or mention to some of our colleagues out there.
Yeah, I think it's a philosophy that there's these patients that are out there that need help. And if our solution is always to reach for a drop or another drop, or there's a role for those things, but doing things that we can do ourselves that take the care of the patient's hands, that are predictable in terms of their outcome, that are fairly easy to do, is we should really be embracing this if you really want to be serious about treating dry eye patients. Doing interventional treatments like in-office conjunctivoplasty or lacrimal occlusion, I think, are great things for the patient and then ultimately for your practice as well.
Thanks so much, Damon. You're the best. Always giving us great, wisdom. We appreciate you taking the time tonight to talk to us. Thanks so
Happy
much.
to do it. Thank you for the invite.